First talk on the topic of the course, which is the super resolution and optical biopsy, going through all the systems that could allow an optical biopsy. That means, as we will see immediately, the sampling of the tissue in the body without active cutting or without aggressive invasion to the body. And the second talk will be related to the telepathology applications in the Amazonia regions, in the underserved areas. In here, a ver, ¿cómo veo yo? ¿Este es el de aquí? Okay. In here, as you will see, there is an endoscopic capsule of the latest generation that have active moving, and that during the presentation we will see that it is also able to take samples from the tissue. First of all, we have to agree on the definition of optical biopsy. There are two types of optical biopsies. Initially, the term of optical biopsy has been applied for the spectroscopy. So nothing related with images. So that means very far from the domain of pathology that we have been, let's see, repeating in here during the whole presentations. The term of optical biopsy, therefore, was done for things that you do not see and that you do not take outside of the body. And this was done just through a spectroscopy. What is interesting is that now methods that allow to see the tissue allow to make the diagnosis. That means that allow to make the biopsy and the diagnostic procedures on images that looks like the ones we have in the microscope. In fact, there are two big groups, the ones based on image, which are related to pathology, and the ones not related with images or not associated with images, which are not related to pathology in Spain and in some of the European countries. But in the States, it's inside of the field of pathology, because morbid anatomy in the European countries are based on morphology, but pathology in the American countries is related with all the biochemical labs and spectrographic measurements. Therefore, in America, this spectroscopy is inside of the field of pathology. In Europe, the only field of pathology is the ones which are based on images. As you can see in this draw, the images you can obtain have different properties, in the sense that depending on the technology, they have more or less penetration in the body. Obviously, if you use MRI, so magnetic resonance, you can observe the whole body. And the resolution that allows you, so that means the distance between the 2 points that is able to discriminate, comes from 0.5 at the present moment on confocal microscopy to big details as it happens in classical MRI, because there are also specific types of MRIs that also have microscopic resolution. The interesting thing is that as much as you have resolution laterally, less penetration you have in the technology. Therefore, the confocal microscopy have a very limited penetration, around 100 microns, but have a very good lateral resolution, therefore looks like a microscope. And this is what you see. This is the reason why the confocal microscope, it's only possible to be applied in surface, because your penetration is very limited. But there are other applications, particularly ultrasound, not CT or MRI, which are the classical fully penetrated applications, but there are applications related with ultrasounds, and this is the PAM, the photoacoustic microscopy, that have a very good penetration. A very good penetration means 3 to 5 centimeters in the body. But obviously, the lateral resolution is less, although it's very good, because 15 microns is a very good resolution. This is the case of the photoacoustic microscopy that we will see later on, in which you can see on the skin, on a surface area, but inside, so deep on the surface area, you can see a melanoma area infiltrating the vessels which are in the subcutaneous tissue. How we can divide the systems based on images? We can divide it according, these have coherent light or non-coherent light, but obviously some type of quality light, because the illumination is structured, or mixed technology. The ones on coherent light is optical coherence tomography, optical coherence imaging, and holography imaging. And the structural illumination includes mainly confocal endomicroscopy, and the mixed technologies, as we will see, include the PAM, the photoacoustic microscopy. And the methods not associated with images, as we will see immediately, are the spectroscopic methods. The topic of the course was super resolution. Why? Because most of these systems, in fact, reach a resolution which is over the expected one. The formula of resolution is that 1, so 2 points can be discriminated when the wavelength of the light and the numerical aperture of the optics fulfill this formula, in which the 2 is multiplied by the resolution system. So the classical ray length formula is at 1, but obviously you can add technology in order to increase the resolution, and this technology, what affects is the N that modifies the resolution of the system. In the ring length criteria, 2 points can be discriminated if the first zero crossing of one of the points is inside of the curve of the other points, considering that contrast between these 2 points is more than 26%, so that means 30%. That means that in order to discriminate, you have to stain, or you have to contrast, or you have to do something. If there is no contrast, as it happens usually in the body, obviously you don't see nothing. There is an issue which is fully exploited at the present moment, and that issue is that the tissue of some tissues of the body and some areas of the body have autofluorescence. So you excite with a wavelength in generally near infrared wavelength, and then you get fluorescence from the spontaneous fluorescence from the body. Obviously, if you get a spontaneous fluorescence, then you increase the contrast, and if this contrast reaches 30%, then you are able to see 2 different points. Another very important issue, particularly in the field of pathology, where it's very common to use CCD cameras, so digital camera CCD cameras, but one chip CCD camera, so that means that the same chip records green, blue, and red information. In general, it's 2 double green plus 1 red and plus 1 blue information. What it happens is that from the resolution, spatial resolution of the chip, for example, if this is for 1000 per 2000 pixels, 1/4 of the pixel belongs to the red detector, 1/4 belongs to the blue detector, and 2/4 belongs to the green detector. The green detector is the main detector. So what you are looking in here, this is a raw image. The classical raw image that you get on the cameras is this type of image, that obviously in order to see in color, you have to combine the information regarding red, blue, and green in order to see that image. And this is the combined image of that one. As we will see immediately, the resolution, the spatial resolution is lost because you combine some of the information. This is what happened with, you have a single chip camera, which is sensible through the 3 colors. The most developed cameras at the present moment are the Foveons, in which you have 3 layers sensible to the 3 colors at the same pixel. Therefore, you don't get this divided by 3 resolution, but you get a very nice resolution with this type of cameras. But these are not very common cameras in the average use in the laboratory. As you can see here, the detail is better seen in the black and white image than in the color image. The reason is that the color image is a combination of 4 pixels which are around, and therefore you lose some of the details, and this decrease the contrast that we have been talking about.
Developed by SpectraScience and just approved by the FDA, brings laser technology to colonoscopy and sigmoidoscopy. This new probe helps physicians determine immediately, with up to 96% accuracy, if any tissue is potentially cancerous.
Well, this virtual biopsy device is a major breakthrough for us because it will allow us to determine immediately when we find a small polyp in the colon during screening sigmoidoscopy or colonoscopy, whether it's a type of polyp that could lead to cancer and needs to be treated or further studies done. Many of them do not, so we can make that determination immediately.
The non-invasive optical biopsy system uses an optical probe to excite and analyze tissue in the colon. The results are instantaneous. Because 50% of small polyps are non-cancerous, it is a great benefit to have this immediate interpretation to determine if removal is necessary. If the tissue is determined to be suspect, it is removed immediately at this early stage when survival rates are the highest.
Well, I like the idea that you can be analyzed on the spot. It certainly...
Okay, this is, as I mentioned, is a structured light, one of the techniques in order to get better resolution. And it's a structured light based on a spectroscopy, so that means based on something which is not images. The only thing you get in here are curves of the concentration of substances which are in the area, and those curves are interpreted as benign or malignant according to a training set that had been done in this system. This means that you do a colonoscopy, and immediately you detect if that polyp or any area is suspicious or not. you take the suspicious ones and you can leave the rest of the items which are not so suspicious. Plus this, which is non-image data, it is called also spectroscopy when you use different colors, so that means different light spectrums or different image responses from the tissue. They call it also spectroscopy, although no, it's not the classical spectroscopy, it's another type of spectroscopy, which include also the images. The classical one are these ones. This is multi-spectroscopy in the sense that you get reflectance, polarization, cross-polarization, blue excitation, and ultraviolet excitation in the same area. This is the cervix of a woman. And from that you can see clearly, and we will see later on, that this is also used in the gastrointestinal area. You can see from the image that the details you get are different from one excitation light to another excitation light. And sometimes they tune all the excitation lines from one length light to another length light, or they automatically select, as we will see, specific excitation lines according to the tissue you are or the pathology you are seeing. The most interesting thing in here is that, as you can see, when you have a loss of fluorescence, this area could be malignant. So that means that you have a lot of areas that you could biopsy here, because who knows if this area is malignant or this, although in general it's just in the columnar squamous junction that you are going to biopsy. But in any case, the columnar junction is very relatively broad, and you don't know where to biopsy in here, but when you get an area such as this one, which you have loss of fluorescence, then you can detect that this is exactly the area that you need to biopsy. Also, there are some intelligent systems, intelligent that it is difficult to trust unless you know exactly how they work, in which combining all these technologies, they select not visually as you have seen in here, but electronically, which is the area of interest that you need to biopsy according to some strange, let's say, parameters which are inside of the device. Let me tell you that according to the European laws, these devices, although they pass the European seal, they are not able to be used on the real persons. Most of these devices, nevertheless, they come from America, and they have passed the FDA, and the FDA requirements are more or less similar to the European mark, CE mark, therefore it will be easy to pass the European CE mark. But on the contrary, there are a lot of European devices that will not pass the European label because they do not have sufficient quality in order to pass the label. Another very important application, which is non-image based, so it's based on the Fourier domain transformation curves obtained excitating the area with infrared. This is a very classical use of spectroscopy for detecting malignant areas, and in the cervix and in the bladder and in the colon do arise a better specificity and sensitivity than the visual and the histological and the cytological acquisitions. Nevertheless, the people are afraid to implement it. They consider they do not have sufficient trials in order to be imposed, let's see, as a better testing system than the classical pap smear. This is the classical, what is called chromoendoscopy, in which you change different wavelengths from one side to another of the spectrum, but in generally you combine different lengths on the red, green, and blue. This system, it's called intelligent, comes from Fouginon, and it's called intelligent because he decides by himself according what he sees on the tissue, which are the wavelengths that should be ideal to discriminate the tissue area. And, this is classically also called chromoendoscopy. Here is one of the cases of chromoendoscopy. It is clear that without changing the wavelength, you see less than changing the wavelength, you see more. In this case, it's not a problem because it's just to see more or less the vessels, but obviously it's much more marking here, and the only difference is just the color excitation of the light, yes. Furthermore, plus changing the excitation color, you can see that the vessels and the hemoglobin are excited at the 450 nanometers wavelength, so this length mainly. So when you have a predominant of this length in the excitation light, what you get is vessels mainly. But plus this change on the wavelength, you can also stain from the outside, improving your visibility of the lesions with indigo carmine. Another non-image technique that is spectroscopic and that had been pointed out already by Konstantinos Pistris, because he's very much interested to combine Raman spectroscopy with optical coherence tomography. You have two types of Raman spectroscopy, the near-infrared and the near-infrared associated with a very high-quality fiber, so hollow fiber in which there is no scattering inside of the fiber, and therefore the quality and the sensitivity and the signal-to-noise ratio is very high. The problem of the Raman spectroscopy is the low signal, and you have to have a very high-quality fibers in order to get a better information. The thing is that you get a series of curves which are different from the normal epithelium to the malignant epithelium, and if we are able to classify it and these differences are persistent in the trial, then you can automatically classify what is the malignancy or the benignancy areas. And this is what we have been mentioned previously, that probably in order to select in a screening of the slide areas which are suspicious, will be better to think on spectroscopy than of artificial intelligence in order to identify the type of cells according to the patholog criteria. The better resolution system, as you have seen, it will rise 0.5 microns, is the confocal microscopy applied on living tissue, generally with endoscopy. The confocal microscopy have a very low penetration, therefore the ideal tissue is this tissue which is more or less transparent, not very thick, so you can see not only the surface, but you can see what is underneath, as is the case of the gastrointestinal tract. Here are two images of the confocal microscopy. One is malignant, the left one, and one is hyperplastic and benign, which is the right one. There are two main fiber optical confocal images right now in the market. One is the Optiscan and the other is the Selvizio. The Selvizio looks smaller, although as you will see it is not, than the Optiscan, which is a regular colposcope, endoscope, in which in the biopsy channel, instead of introducing the biopsy sampling cable or fiber, you introduce a confocal microscopy fiber, which is that one. In general, the diameter of those fibro microscopes are 1.4, sufficient to be introduced through the biopsy hollow of a regular endoscope, and contain 30,000 fibers, each one of 1.9 microns. And on the top, at the end, there is an optics, a rod length, which is the Green's length. In general, only 4.8 plus, and with a low numerical aperture, because they are just detecting low detail or low power detail like in the microscope. And the resolution achieved is around 3.5 microns. Now we will see.
Is a newly developed diagnostic tool enabling in vivo histology during ongoing endoscopy. To create confocal images, blue laser light is focused on the desired tissue via the distal end of a pentax endoscope. The special confocal optical system detects the fluorescing light, which produces high-resolution microscopic images. Handling of the endoscope is similar to that of a standard video endoscope. Confocal images are displayed simultaneously with video endoscopy images on two separate monitors. The endoscope is advanced over the esophagus. The blue laser beam is readily visible on the mucosal surface. Now the pylorus and the inflamed antrum are visible. 5 milliliters of fluorescein is injected as a contrast agent at a final concentration of 10%. Fluorescein is mandatory for endomicroscopic imaging. It highlights in vivo architecture of the mucosal layer, primarily vessel architecture. The fine capillary network in the antrum is readily visible due to the bright bands characterizing single capillaries. Dark spots within the capillaries represent red blood cells. Subsequently, a second dye is applied topically to the gastric surface. Acroflavin is sprayed with a spraying catheter onto the mucosa. Acroflavin highlights cell boundaries on the nuclei. In addition, Helicobacter pylori are brightly stained due to an active uptake of acroflavin. Accumulated as well as single germs can be readily visualized on the mucosal surface and between the gastric glands. Foveolae gastricae, epithelial cells, and Heliobacter pylori can be differentiated. The typical shape and size of single H. pylori can be identified and could possibly allow endomicroscopic targeted biopsies after more research is conducted. The confocal endomicroscope is positioned in the lower left corner in the endoscopic view. During confocal imaging, suction can be applied through the working channel to the tissue in order to minimize moving artifacts. The working channel is localized at the right lower corner. Thus, biopsies should be targeted at the left side of the suction marks to obtain corresponding specimens for final histology. Ex vivo histology revealed Helicobacter positive gastritis. The patient was subsequently treated with antibiotics.
Well, you see the technique. We see the technique in here. that in order to see the tissue, we have to make some contrast. Otherwise, it's impossible to distinguish the tissue itself. And the contrast is done mandatory with fluoresceins in order to see the vessels, and also with a spray-on surface with acroflavin, or with methylene blue, you will see later on. Because the methylene blue mainly stain the nuclei, and the acroflavin stain the boundary of the cells, and also the bacteria, in this case Helicobacter pylori, and on the second phase also stain the nuclei. But the point of acroflavin is that it's mutagen. So that means you can use it for diagnostic, but not in a repetitive manner. This is when you use colors, so dyes like indigo, carmine indigo, or methylene blue. You can call also this chromoendoscopy, because you just not only see it macroscopically in color, but you also see stain the nuclei inside of the endoscopy.
Year-old male patient is scheduled for chromoendoscopy and endomicroscopy because of dysphagia. Subtle irregularities are visible in the middle third of the esophagus. Some nodularities and shallow ulceration are present. Lugol's solution is sprayed onto the surface using a spraying catheter. The iodine within the solution binds with glycogen within normal squamous epithelium and leads to a brown colorization of the surface epithelium. Neoplastic and inflamed areas remain unstained. A large area of unstained mucosa becomes visible after intravital staining. The borders between the suspected neoplastic lesion and the normal squamous epithelium can be easily identified. Chromoendoscopy is used to unmask the area of interest. Subsequently targeted endomicroscopy can be performed. The endomicroscopic window is positioned in the lower left corner within the endoscopic field of view. Images can be obtained following gentle contact and pressure with the endomicroscopic window at the mucosal surface. Fluorescein is injected as a contrast agent for endomicroscopy.
Well, this is for the
Squamous epithelium is displayed as gray cells with low contrast. However, capillaries are brightly highlighted in the lamina propria. Here, irregular and twisted tumor vessels can be identified. Changes in vessel architecture
is on time, so that means that it's moving. It's not a very nice image that you have seen previously.
Different depths using additional buttons of the endoscope control body. Subsequently, acroflavin staining is used to further characterize cell architecture. Acroflavin is also applied over a spraying catheter. Acroflavin highlights surface cells. Nuclei and cell membranes become readily visible. The normal squamous epithelium looks bright with homogeneous and very bright nuclei. Malignant cell changes are rather dark and irregular. Confocal images are displayed every 0.8 second. The number of moving artifacts can be minimized by gentle pressure of the distal tip of the endoscope onto the mucosal surface and by continuous suctioning. After stabilization is reached, suspected areas can be imaged over the whole imaging plane depth. Here, irregular cell architecture indicates squamous cell carcinoma. The different confocal images can be digitally captured with the help of a foot pedal. Online obtained images can also be reassessed at any time after the procedure. Here, the tumor vessel seen after the application of fluorescein is further magnified and colorized. Malignant, irregular and dark changes are seen in contrast to bright normal cell architecture of squamous epithelium after local acroflavin application. In the magnified mode, single cells with normal nuclei are marked with an arrow at the right. The malignant changes are highlighted with a second arrow at the left. Endomicroscopic guided biopsies revealed a poorly differentiated squamous cell cancer.
Okay, so that means that we can do chromoendoscopy. In this case, it's like a screening endoscopy in the sense that you stain the area with Lugol, iodine, in order to mark the areas that contain glycogen, which are the normal cells, And those areas that does not contain glycogen could be pathological or malignant. And furthermore, you do microscopy with microfluorine and fluorescein in order to see the areas of malignancy transition. As you have seen, there are some malignancy. But furthermore, you can also immunostain the fluorescence, so make immunofluorescence with a specific antibodies. Some of those antibodies could be, or could determine, or could detect specifically pre-malignant or malignant areas. Therefore, you can go directly and selective to the area of interest.
How are you currently imaging the lungs?
This is the Cellvizio.
Frozen in an X-ray image? Or under a CT scan? Inside the bronchus using a bronchoscope? Or outside the patient's body analyzing samples under a microscope? Cellvizio Lung opens a new world in pulmonology with in vivo, in situ imaging of the entire bronchioalveolar tract with microscopic resolution. Cellvizio by Mauna Kea Technologies. For endoscope stop, Cellvizio Lung begins. Cellvizio Lung enables doctors to safely reach distal areas in the lung. It produces reliable, ultra-high resolution images of the alveoli as it lives and breathes. Of the imaging modalities currently available, none can produce live microscopic images of the alveoli in real time. Standard bronchoscopes cannot reach the distal lung, and obtaining biopsies can be risky. Even when samples are safely taken from the patient's body, histology cannot provide functional or dynamic information.
Quand l'anatomopathologiste fait des coupes de poumons,
one of the problems when you see the lung pathology is that when you cut it, you scratch it, and the area, the alveolar area is completely crushed.
L'aspect que l'on voit sur une coupe de poumon est un aspect 2 dimensions et qui est celle d'un poumon non seulement non aéré, mais également d'un poumon qui n'a pas son architecture dans les 3 dimensions telle qu'il doit l'être.
Cellvizio Lung begins where bronchoscopes stop. It can reach the alveoli and visualize their dynamic process at a microscopic level. Specifically designed for microscopic observation in the lung, the system comprises a laser scanning unit, the Alveoflex confocal mini probe, and a proprietary image processing software. The physician performs a standard endoscopy procedure. When the bronchoscope reaches its access limit, the alveoscopy procedure begins. The Alveoflex is inserted into the operating channel of the bronchoscope and extended further into the terminal bronchi or alveoli. The tip had been graduated for landmarking purposes and to further ensure patient safety.
Since the tissue is transparent, you don't need to manipulate it, you don't need to punch it, nothing at all. You just put the light on the surface, that's all. And this is what you see. You see the alveoli breathing.
At the heart of the Cellvizio system lies a unique patented laser scanning unit, LSU. The LSU integrates a blue laser diode. Its beam travels via a system of lenses and mirrors, thinning it to a micron scale diameter. At the end of its course, the beam is injected into the Alveoflex mini probe's fibers with unprecedented scanning accuracy and speed. The Alveoflex confocal mini probe is 1.4 millimeters in diameter and is comprised of 30,000 optical fibers. The core of each fiber is 1.9 micron. Each fiber is injected 12 times per second in a rapid sequence, one after the other. The laser beam travels through the fibers of the confocal mini probe until it reaches the area to be examined within the patient's body. The laser scans a 600 micron area of living tissue, and the resulting lateral resolution is 3.5 microns. Cellvizio Lung takes advantage of the naturally occurring fluorescence of the lung, revealed by the blue laser. The light re-emitted by the scanned area is collected by the confocal mini probe and guided back to the LSU. With its proprietary software and image processing algorithm, it produces real-time microscopic video images of alveoli that are viewed on screen and recordable. Cellvizio Lung is the result of 6 years of research and development by Monekea Technologies in France. A multidisciplinary team of professionals from the fields of biology, medical optics, astrophysics, imaging processing, and computer engineering work together with a singular objective: to provide clinicians with innovative, minimally invasive imaging devices that improve pulmonary patients' lives in routine procedures. Cellvizio Lung has the CE.
Okay, you see this probe, which is inside of the endoscope for the lung, looks smaller than the one we have seen on the Pentax on the Optoscan. But it's exactly the same size. It's 1.4 millimeters and 30 K number fibers of 1.9 microns each one, and the same resolution as the previous one. But the coating is almost transparent and very thin, so therefore it looks like only one fiber, which in fact they have 30,000 fibers scanning the area. Obviously now there are confocal probes in which there is only a single fiber. This single fiber have to have a lot of very high quality on the material in order not to spread and lose the light. Now we come to another type of structured light system for spectroscopy and real biopsy. And this is the video endoscopic capsule. This is a pill that you swallow, and it goes through the intestine, taking images from the intestine. And as I mentioned previously, the first generation was the M2A from Imaging Technologies, I think is the name. Now the second generation is from Olympus, Norika, and Sayaka is the one we are seeing in here. The Olympus is the less evolved one because, as you can see, the camera is on the top, on one vertex, and the most developing ones, the camera is lateral placed, and the reason why it's lateral placed, you will see here, is because meanwhile they are rotating, and they are rotating because they have in here, I mean, they do not have power inside, they have power, but they do not have batteries inside of the pill. They are charged from the electromagnetic field from outside, and the electromagnetic field from outside, which is handled by the patient. These are the leads, by the way. These are the leads, that can be different type of leads, for fluorescent leads, white leads, different type of wavelengths in order to do spectroscopy. So these are charged from the outside, and meanwhile they are charged, they are rotating the pill. Therefore, meanwhile they are moving through the intestine, he is rotating and getting charged, and taking pictures from everywhere. obviously they are coated. And at the present moment, meanwhile, they are using radio frequency ID in order not to lose the device inside of the intestine, especially when they have stenosis. So you will see how it works. It is rotating, and discharge it and move the pill around, and taking pictures from all over around. So they are not only tracking, but also taking pictures from all over around. And these are the leads of different colors. This is only useful for the small intestine, because the lumen is relatively small, but in the large intestine, the pill move around and get lost. You can have, if you are lucky, some pictures, but probably of not very good quality. Esophagus. Stomach also you get lost more or less, although this pill is tracked from the outside, so you can move it in such a manner that you can push it on the lateral walls and therefore take better pictures. But obviously in the small intestine is very fine, because the walls of the intestine are touching the surface of the pill, and you are taking pictures all over around, and thereafter you build it as a mosaic, like here. You stitch and build a mosaic. Taking picture of all around. The speed is very high, and you are taking different pictures. You are sending the pictures outside. Obviously, this is a wireless connection. And in the system outside, the pictures are getting built in a mosaic form. One of the problems of these capsules is they can get stuck somewhere. And in order to avoid get the capsule lost, not because it's a problem to get it lost, because it doesn't matter. Now I think that they reuse it. Initially it was one use only. The problem is that they can block the gastrointestinal transit, particularly when there is a neoplasm. That is the reason why the 4G, the fourth generation type of capsule is built with legs in order to impulse themselves inside. And not only that, but also not only is built with legs, but it's also built with some kind of devices that can go from the inside to outside, take the biopsy. The capsule is almost empty. So that means that you can put inside a lot of things. You can put treatment, you can put immunodetectors, you can put a lot of things inside of the pill in order to make the diagnosis. And the system is tracked and moved, although this is the Olympus, the previous generation, but in any case the system is tracked and moved from the outside with an electromagnetic field, and in outside you can see the images directly. Another type of images you can get are the interferometric technology that build images. There are a lot of techniques of interferometry, including single fiber interferometry, in which they use photonic crystal fibers, optical coherence tomography, as we have seen, optical coherence microscopy, and full-field optical coherence tomography. The difference in microscopy obviously depends on the greens. That means the numerical aperture of the optics, which are on the top of the fiber. This is a case of a single fiber interferometry. In the microscope, optical coherence tomography, your greens, your numerical aperture is less than, is more than 0.5, and the greens can get even up to 1.2. But obviously, if you have a lot of detail, your penetration is less. So you have to move in between what are the needs inside of the medical application. Optical coherence tomography, as you have seen in the previous talks, have improved a lot, but mainly have improved through the type of light source, from the superluminescent diodes to the laser pulsed and the ultrafast laser pulsed. This is the latest generation that have an ultra-high resolution up to 0.5 micrometers. So it's a very good resolution that allows you to obtain almost microscopic images from the things you are viewing. But interesting enough is the fact that even using halogen lamps, in a macroscopic view optical coherence tomography, you can have a very good resolution. You can have an optics of 10 per with a numerical aperture of 0.3, and with a spectral coding of the images you get, you can have like a full biopsy or histological image of the area you are seeing. The most advanced technologies include the, as we have seen yesterday or the day before, the optical frequency domain imaging, so the Fourier transform domain, which is a lot of computer consuming in an imaging rotating system. So the top of the catheter rotates and furthermore move the wavelength from 1,200 up to 1,400 nanometers, getting all that information simultaneously, so the imaging around 1,000 points at the same time. And the latest system, which still have difficulties due to the speed, the lack of speed in order to obtain information from the interferometer imaging system, is the terahertz interferometer imaging. Well, this is the type of data you get in the ultra-high resolution optical coherence tomography, either in endoscopy, so meaning in surface areas, or inside in surface areas, or in fibroscopy, meaning that you punch, you put the coherence tomograph inside of a needle and you put it and you punch the surface in order to get information from the inside body. What is nice from that is that you can obtain information without needing to have real physical biopsies. For example, in here, you can see if the area of breast you are cutting in a breast surgery is free or not of tumor. In here is free of tumor, therefore there is no problem, you can cut. And in here, the area have a tumor, therefore you cannot cut. And this is the histological image from the area you are cutting. Therefore, you have to go further on in order to cut. It is clear that the quality of the images you get cannot be compared with the confocal microscopy we have seen, but on the other hand, particularly for internal organs in fibroscopy, you get images that are quite similar to the microscopic ones, and therefore they have sufficient quality for making diagnosis, particularly when you are looking of the sentinel lymph node, if this have neoplasia or no, in order to proceed the surgery. They are, nevertheless, smart image analysis techniques in order to improve a lot the quality of those images, and you can see here that with this interferometric synthetic aperture microscope, you get the image focus even in deep, and furthermore, you get details which are similar to the histology. And even in the, if you use an halogen lamp, in the full field optical coherence microscopy, you can coat the image in a spectral manner in hue, saturation, and luminance, and get a detail of the, for example, epithelium that looks like an histology. And you get, in fact, a lateral resolution of 1.4. Therefore, if you are using this system for colposcopy, this is quite fine. Another new technique, which is a little bit far from what the pathologists expect on the images to see, is the holographic techniques, although on molecular point of view it must be of a lot of help. This is the holographic imaging, holographic microscopy, and quantum holography. In the quantum holography, the light you are using are electrons. Therefore, the information you get is very small. It's at the quantum limit. The interesting for some medical applications of the holography is that you correct a lot of viewing problems of the area. So you correct for deepness of the image, you correct for lateral deformation, lateral vision, and therefore in some areas, like for example in breast, or even when you are planning surgery in the spine, an holographic imaging display on particular monitors as this one could be of interest. There are also holography, as you will see in microscopy, but this is for the biological area and far for us. Also, it's far for us, although extremely important for medicine and for genetic therapy and things like that, all the area of nonlinear illumination that built chemical microscope. What means nonlinear illumination means that the incident light is not reflected, is different from the light that you receive, is non-linearly received. And you have the CARS, the coherent anti-stroke Raman scattering, CARS confocal, nonlinear interferometric vibrating imaging. Those things, they detect the vibration of the molecules. So, in fact, they are chemical microscope, not really imaging microscope. You have one photon, two photon endoscopy, second harmonic endoscopy, near field scanical optical microscopy, in which you have to have the sample very close to the area of electron beam. But you get, on the other hand, a very high resolution of 20 nanometers, the scattering near field scanning microscope, and obviously the atomic force microscope. But the interesting thing are the hybrid methods. Although I already asked Konstantinos Pitris if he has experience on the PAM, on the photoacoustic microscopy, I didn't get a clear answer of what he had said. The only thing that was clear to me is that this is very expensive, which I don't know exactly why. It doesn't look to me that it should be, but in any case. There are three types, and I want to pay attention on all the three because they are very interesting. Particularly the middle one. I don't have images from the middle one because this is a very recent one, and let's say it's a very stupid method. But it gets a resolution of 3 nanometers, which is a lot. And the stupid method is that they put on the top one image focus in different focus on Z localization. So you have you take several images on different Z localization, and you make the difference between those images. And this difference will allow you to get 3 nanometers differences. So you can detect things which are very, very small. This is the through focus scanning optical microscope imaging. It's just subtracting images in different Z positions. Obviously in a very nice and very precise scanning system on Z position, but it's, let's say it's a very stupid method, and they get a very good results. More intelligent methods are the PAM, the photoacoustic microscopy, particularly this one, and the diffuse optical tomography, that is a functional near-infrared tomography. You excite the area, for example, the breast, with near-infrared, you get the optical density image, you get the second derivative of this image, and thereafter you code the different wavelengths in the spectral window. The spectral window has already been brought by Konstantinos Pritis, and in fact I took these images from him. The spectral window is from 700 to 900 nanometers wavelength, and is a window where the hemoglobin almost do not scatter, the water also do not make any information, and the tissue scattering is in the middle point. When you coded the 4 wavelengths, there are only 4 codes in here, 4 colors. If you code the 4 wavelengths, you get details which are not seen in normal even mammographies. And this is a cancer in this area of here of less than 5 millimeters of diameter. Obviously, you can mark also the things with beacons. You can mark molecules which can be excited with the infrared in order that they go directly to the areas of interest, and then you do the dot, the diffuse optical tomography, and then you see where those areas have been deposited. The nice thing of the photoacoustic microscopy that we will see immediately is that this is an ultrasound technique. Therefore, they get the penetration of the ultrasound. They get 3 centimeters of penetration, but they have the lateral resolution of almost a microscope. This is based on the fact that if you use a very short pulse laser in a tissue, you get a vibrating wave from the tissue, and this vibrating wave, which is a thermoelastic expansion of photoacoustic wave, can be detected by an ultrasound probe. And with a high-quality ultrasound probe of 5 millihertz, you can, and 800 nanometers light, you can get a deepness, because the nice thing of this system is the super depth. with a high lateral resolution. You have a super depth resolution, and this is the images you can get. There are very few images. This is the only one I could bring for presentation. Now, this is what we get in non-invasive techniques. We get images that, besides the spectral images, are close to the pathology area. This is one of the reasons why the endoscopists or the doctors do not feel comfortable on doing this or self-sufficient for making a diagnosis, because they are not really trained on morphology as the pathologists. Therefore, this should be supported by pathology, not physically in the area of endoscopy, but at least at distance. And the problem is the way the pathology have to be trained. And I'm going to show you 2 slides of the way the knowledge comes to medicine. They are very funny slides, because you will see that the knowledge of pathology are different from the knowledge of the rest of doctors. The way we get the information is not similar to the rest of doctors. The first slide is the, let's say, non-good based knowledge for doctors. But these are knowledge that exist. I mean, there are doctors that base their knowledge on eminence, on vehemence, on eloquence, on providence, on loss of confidence. So I mean, instead of being, no, this is that, in order not to show that he is not sure of what he is doing. Nervous-based, this is very clear in medicine. Confident-based, just the opposite, those which are very self-confident and are sure of everything. And it comes now that it's wave-based. And many of the medical doctor wave-based medicine are brought by the patients themselves, because they go to web and they even learn more than the doctors when they are in the School of Medicine. So these are issues that have to be taken into consideration. Now they come the higher level of knowledge, or let's say the more scientific part of the knowledge in which the medicine is based. But some of them, it looks really suspicious, even though. They are preference-based, and this is more related with the schools. There are schools that behavior in that way, or behavior in the other way, or made the diagnosis in this way, or made the diagnosis in the other way. They are subjective judgment, and this is clear. Everyone knows that you can make a diagnosis as soon as one patient comes into your room. It's fully subjective, but it's regarded or based on knowledge that you have from behind. They are consensus-based, which I don't like at all, by the way. They are outcome-based, which I like better, and then the top of the top, and on which everyone is going to be basing the medicine up to now, which is the evidence-based medicine. So you have sufficient experience in order to assure that what you are saying or the treatment you are putting is the correct one. Then it comes the pathology knowledge. The pathology knowledge, the gold standards for the pathology are completely different from the rest of the doctors. They do not care on the evidence, because the evidence at the present moment is not available. They are based on experience. They found the knowledge, the only way they have found the knowledge is from the literature, and the only way to find the knowledge in the literature is just seeing images, because there is no way to, I mean, you can learn on the literature medical-based evidence of the follow-up of a patient that had been treated with that and that and that. But you cannot base your knowledge of pathology unless you see the image. So you are based your knowledge on the image comparisons. And this is the reason why we are pushing so much the project of training pathology quick with imaging comparison quick, in order to have as much as possible have the pathology trained on a new tool as this one. Obviously, there is an eminent role. I mean, in pathology, everyone knows that they say this is this because I say that this is this. That's all. Full stop. No question about. And this is this because I'm an eminence on the area of the pathology we are talking about. This is based on interpretation, which is obviously nothing to do with evidence. You just interpret the things in the way you think they should be interpreted according to your experience and the images you have seen previously. And you have a sixth sense, or sexto sentido in castellano, that when you see something, this smells to me like a neoplasia. And probably your first impression is the right one. So you mean that the knowledge of the pathology doesn't have anything to do with the real nice knowledge? Oops, no. Sorry. The real nice knowledge, which is the evidence-based knowledge. So pathology are not guiding for that. Therefore, how can we provide the knowledge to the pathologist? And I say to the pathologist because the endoscopists do behave in a different manner. I mean, these are not based on images. They are based on evidence-based medicine. So how can you bring the knowledge to the pathology? The only way to bring the knowledge to the pathology is to bring sufficient image comparisons and even to leave the system automatically to find the comparisons in order to bring to them to make the diagnosis. And this is everything for today. Thank you very much.